The liver, you see the upper border, you see here, upper border, lower border, right? Then the edge, that's very, very important. So normally the liver is the liver topography, or liver means the liver, the structure of the liver. This means the structure, okay, anatomy, topography. 8 to 12, that means 10 plus minus 2 centimeter, okay? It's liver, okay, the length. The size of the liver. Below coast, it is usually below costal margin, and it is edge. It has got the edge also, and the lobe, the right lobe and the left lobe. Remember, surface and consistency. The surface is smooth or irregular consistency means surface. The consistency is soft and it is hard, like hard in case of cancers, right? Remember this. Whether it is tender in congestion of liver, in liver abscess. If it is due to the, you get right heart failure, then you get a liver congestion of the liver. In hepatitis also you can get. In abscess you can also get. Like, so you can get tenderness. In initial part of the cirrhosis you can get. So any infection, any inflammation in the liver, you get the tenderness. Then the bruit. Bruit means you can hear the hollow, harsh sound. Okay, so that is the bruit. That is because of the hepatic cell carcinoma, the tumor of the liver cell, cancer, okay? Or there is perihepatitis, inflammation, perihepatitis, there will be bruit, and in case of spleen, there will be perisplenitis. And here the bruit is because of perispleen. Then it is bellotable. Bellotable means whether you do and you can feel it. No organ except the kidneys are bellotable, right? You push from the downward from the left, it can touch the upper part. This is the patient, this is my left, and you push on the below, and it touches this. If it is kidney, right? Kidneys are usually bellotable, but no any other organ. Now you should see the upper border of the liver, right? Right lobe and left lobe. These are very two important. Right? It has got the two lobes, right? So fifth rib 2 centimeter, middle to fifth rib 2 centimeter, medial to the right mid clavicle. Okay, so usually it starts from the fifth intercostal space. So fifth rib, fifth intercostal space, medial to 2 centimeter medially. Okay, below the right nipple, you start. That is the upper border. Okay, that's very important. And left lobe at sixth rib, it is at the fifth, and because left lobe is down, little down, right? If you see the liver. You see the liver here, you see the left lobe is down, slanting, right? Yeah. So it is sixth rib at left mid-clavicular line, same mid-clavicular, but instead of 1 centimeter, it is 2 centimeter below, because it is going downwards. So the right lobe 1 centimeter below nipple, and here it is going 2 centimeter below nipple. So that is very, very important. The upper border, the lower border, right costal margin and left costal. Right is ninth costal margin. Ninth means the ninth rib, right? Ninth rib, right costal margin, and the left side is lower border. The left side, right side is ninth costal, and left will be eighth costal margin, diagonally. Edge moves 1 to 3 centimeter in inspiration. You see the edge here between this edge. Can you show me edge? Show me edge. There is this. There is this. There is no nothing. Oh, very good. This one. There is the edge. 1 to 7. So liver moves on inspiration. Where? Up or down? Down, right? Because the lungs, when they inhale, lungs get expanded and it pushes the liver down, right? And in inspiration it comes up and pushes the liver out. So usually, if the liver dullness is in the fifth, if it is if it is not in the fifth, if it is in the sixth. What does that mean is there is, and it is resonant. That means it could be because of emphysema. You see, it is resonant. It is not dull. So the lungs are expanded too much. What is the condition? Emphysema. I think I should also go.
Yes.
It's too hot now.
Yes.
So move 1 to 3 centimeter. Edge move 1 to 3 centimeter by inspiration. So remember this. Okay, liver. Usually liver span. It moves down and pushes this. The diaphragm and abdominal is taking out, right? Moves the abdominal out. So this is very important, the liver, right? Now you know the upper border, you know the lower border, and upper the right lobe and the lower lobe, right? So you can know the anatomy, right? The lower is 1 centimeter below the nipple, medially 2 centimeter medial, and the left lobe is 2 centimeter in the sixth rib. Mid-clavicular line, please, here, mid-clavicular line, sixth rib here, and 2 centimeter below the nipple. So that is the upper border. Lower border is the costal margin, ninth costal margin, and left lobe is the eighth costal margin. Okay, then edge moves, crosses midway between the, edge moves 1 to 3 centimeter by inspiration. So various things you will see these things, right? Size, shape, surface, consistency, yeah. Bruit, these all things you will see. Tenderness, friction, rub. There is the rub also, friction,
Yes.
That is in perihepatitis, both. In spleen also there is spleen rub. That is perisplenitis, inflammation. What? Infarction basically is the infarction. Infarction, yeah. The blood vessels, there is arrest of the blood supply. So it causes friction rub. Remember this. GB surface marking, you don't have to go, okay, it is here, right corner, you know already about this, okay. Palpation of the, okay, now technique of spleen. Okay, then usually what happens now, okay, now the important the application, how you go the palpation of the liver, right, start from the right iliac fossa, go above. Breathing and breathing with each breathing, with each respiration, expiration, and inspiration, go move 1 centimeter at one time. 1 centimeter with each breath, 1 centimeter with each breath. Go upside, up. Okay, 1 centimeter. Okay, remember this 1 centimeter, and your finger. These two fingers, they should be parallel to the which one? The rectus muscle. Okay, the rectus muscle parallel, and goes up slowly. First is the superficial. So you go up 1 centimeter, the breath each, and don't go just push too much inside the costal margin like this. No, inside. No, slowly. And during inspiration, tell him to hold the breath, and you will see if there is the edge of the liver. You can see. Okay, you can feel the edge of the liver. That is very important. If you can feel the edge of the liver, that is important. Then you will see if it is enlarged, then you will also find if it is enlarged. How many centimeters below the costal margin, you will tell me that, right? So that it is enlarged, right? But sometimes the liver, you feel the liver edge, it doesn't mean every time it is enlarged. See, now tell me the condition. Because it could be not the liver size is normal, but the lungs have expanded, so it pushed the liver down. So the liver size is normal. So don't think the liver cell, if you feel the liver cell, it is always enlargement. It's not always enlargement. So before that, you should see that patient has emphysema, COPD. So his lungs are expanding too much and pushing the liver down, and you feel the edge. Even you feel the liver like 1 centimeter, 2 centimeter below the costal margin, depending upon the status of the emphysema. Okay, so that is very, very important. That is important. So liver 1 centimeter, same thing with the spleen also, but you go diagonally from right iliac towards the left corner, okay? From the diagonal. But here it is up. Again is the rectus sheath, this index and the middle finger, and you feel the liver edge, right? If it is enlarged, you feel whether it is tender or non-tender, right? Whether the surface smooth or surface is hard, right? Hard is not good. Soft or not smooth. Soft, whether it is soft surface or it is hard. Hard means because of the tumor, because of metastasis from any part going into the liver. So metastasis liver gives the hard, okay, nodular liver. So hard and nodular, liver cirrhosis gives nodular, okay, liver cirrhosis gives nodular. Then soft and this. Then if it is the what we call this, the size, shape, then surface, surface I told you, yeah. Smooth surface, or it is irregular also. The edge you have to see. Edge is how much it is irregular. Then tenderness you will see. Okay, so these are the various things you will find out on the palpation. So palpation is very important of the liver. So 1 centimeter, 1 centimeter, don't move up. You see, yeah, parallel, always parallel. Don't move you do this, you palpate, then remove your hand. You palpate, you remove. So if you will get the slab. So never do this in your life. So like this, like reaching the right hypochondrium, right costal margin. Okay, inhale, exhale. Inhale, because it will push this, then okay, you should stop, okay? Just hold the breath, then you will find out, right? And for the size, for the length, from the mid clavicular, fifth mid clavicular, okay? So that's very important. So you can see the how much with the tape. So that's why all examination you need the tape, inch tape, you need everything there, right? So you have to be very cautious about that. So now the spleen, in the same thing, the spleen is done by 3-4 methods. You see, usually fifth is the spleen in the spleen is in the where. So there is one is the classical method. One is classical method. Only you do like this, like the liver, starting from the right hypochondrium, right iliac fossa, going towards umbilicus diagonally towards this, because it is in there. Because why diagonally?
Because they enlarge the spleen.
Yeah, very good. Because the spleen enlargement is towards the umbilicus. You see, the liver enlargement is not diagonally; it is downwards. But the spleen goes towards this, diagonally towards umbilicus. If the spleen is enlarged too much, it goes up to umbilicus. It goes below umbilicus even. Massive hepatomegaly. Sorry, splenomegaly. You know, when it goes below umbilicus, there is massive but if it is up to umbilicus, it is moderate between umbilicus and this costal margin. But if it is below umbilicus, it is massive, which certain countries. Though then the spleen, this is classical method. Okay, you don't ask him this. Then if you don't palpate, then what you do this? Then you do the bimanual. In bimanual, you ask him to lie on the right side, right? Turn on the right side and keep this hand below the left side of the chest, okay? And because it is 9th, 10th, and 11th mid axillary line, and posteriorly also, if you know the spleen, the anatomy, so push this, and if you can push and you can palpate it. That is bimanual. And you go up with this diagonally, and you push this. That is bimanual right turn, okay? Right, it lies on the right side. Then of the bimanual is another is the hooking method. Hook, not hooker, hook. That I want to know this. That means all of you are very bad guys. Wallah, I will show application basically. You put this and put inside the left costal margin, and you can feel the spleen, this hooking. Then hooking, after hooking is then we got classical bimanual hooking and the dipping method. Same like the classical, like this. But instead of one hand, you have two. Dip into this. Why? Because of ascites. In ascites, you cannot find the spleen normally, right? So you have to use the dipping. Too much dip, then you can feel the spleen enlargement. Remember that. So 4 things, right? Classical, dipping, hooking, and bimanual, right? This is very, very important. So same thing also here. Then the spleen. What is spleen? You feel the spleen edge, right? Spleen is usually not palpable. It is palpable when it is 2.5 to 3 times enlargement. So always if spleen is palpable, that means it is enlarged. That means it is enlarged. So it is how it is enlarged. That's very important. It has got the edge, right? You can see, you can palpate it, but not go above that. Like, because there is a costal margin, so you cannot go above the swelling. Above the spleen. When you palpate it, right, above the surface. So above the surface, you cannot go. You can feel the spleen has got edge. What else it has? What else it has got? It has got the notch, spleen notch. Notch is very, very important, and the swelling goes towards the umbilicus, right? Towards the umbilicus. While the difference between the spleen and the kidney, the difference between the kidney and the spleen swelling is what? The kidney is rounded, globular, rounded, right? It also it moves during inspiration downwards. Remember that. Spleen also moves during inspiration, but not this diagonally. But kidneys moves inferiorly. It moves inferiorly, okay? It is rounded, and you can feel above the kidney it is retroperitoneum, right? So you can feel the colon, okay? When you go above the kidney. But here because above the costal margin you can feel nothing. But here this kidneys are rounded. I told you they have got the what else they are? They are bellotable. They are bellotable, rounded. They move inferiorly, right? The kidneys. What else? And this is all about. This is the difference between this should be very important. Difference between, I will ask you the difference in the exam. The clinical exam is very, very important. Difference between the spleen and the kidneys. How you will find this out, right? Goes towards the umbilicus. This goes inferiorly. This has got notch. The kidney is globular, and goes inferiorly down, round. Yes, that's very important. That's very important. So that's about the spleen and so kidneys are bellotable, right?
Yes.
So this is very important. Then percussion, spleen, kidney, liver. So you also read at home this. This is very important. Then we got the palpation. Then you got the percussion, right? So palpation, you do all the. If there is any organ, as if you said, if there is any mass, so you have to see the mass, whether it is movable or it is fixed, right? It is tender or it is not tender, right? So there's temperature. If it is hot, the place is hot. It's raised or not. Temperature is raised or not. That's very important in the mass. If any mass, right? Mass is very important. Okay, and the mass differentiation between intra-abdominal and extra in the abdominal wall. So that's very important.
Yes.
So bruit, then you have got the splenic rub also, friction rub because of perisplenitis or infarction of the spleen. So rub is because of the infarction of the spleen. So it will be consistency, smooth surface, whatever, hard. So in tumors, bruit or bellotable. So after that, we will see examining the kidneys. You see here, the right kidney is lower than the left. Yeah, right kidney is lower than the left, right? So starting from the percussion for the epigastric umbilical tympanic dullness. So percussion is easy. One is percussion of the in dullness. Starting your percussion with this middle, with this one and this middle flanks, right? This one middle flanks. So you go from the midline and move towards the flanks. Okay, and ask the patient. If there is any tympanic, then there is little dullness. Okay, then is dull, straight, his spine position and there is dullness, right? And ask the patient to move towards the left side, for example, right? Move towards the left side and wait for the 10 seconds because the fluid will gravitate towards the left side, all the fluid. And you now start the percussion and it will be tympanic, it will not be dull. That means the fluid has shifted. So we call it shifting dullness. So dullness is, so there is shifting and it causes the fluid causes dullness basically. But when you shift, it causes tympanic, right?
This is percussion of what?
Percussion of the abdomen,
Not specific.
not of the heart. Huh?
Not specific organ.
No, this is for the fluid.
Fluid.
Percussion you see for the shifting dullness and for shifting dullness. And for if you have massive ascites, what you will do? If your ascites is too much, you cannot have the shifting dullness because it is too much fluid. So you cannot patient asks, no, the fluid will not go here because it is too much fluid. So equal. So usually there is a shifting dullness, there is usually maybe half a liter of fluid, okay? 300 to 500 ml fluid, that can cause the shifting dullness. But if it is large amount of fluid, there's no, what you do? You do fluid thrill. You do the fluid thrill. What is fluid thrill? You keep your left hand on the left side over the left side of the abdomen and on the right side of the abdomen, flicker with the finger, flick it. And the waves will go, the thrill. Okay, you will feel the thrill on the left side of the abdomen. On the right, this will feel the thrill with the left hand. Because the waves goes towards this with this, because the water has the movement, right? The water goes and splash, I mean water waves, and it touches your left side. That means it is fluid thrill. So that is in case fluid thrill we go for in case of massive ascites. And if it is you don't get the thrill properly, so you have to keep the midline. Ask the patient or somebody to keep the scale in the midline and push it little down. Right? Unless you do it in the application, you cannot. You don't understand this, right? You should read also fluid thrill. So keep the hand, and while you keep the hand, because it stops the waves going to the skin. So instead of going to the skin, it goes to the peritoneum, and you feel the waves in the left side. Right side you flick, and left side you feel the thrill. So this is in case of ascites. Okay, so this is percussion, right? You see here the fluid thrill here. This one, this hand. This, see here. This one is in order to keep so that the fluid goes directly, the thrill goes directly towards this side, right? So it flicks from here and goes here. So it stops going into the skin. Percussing the abdominal. Splenic percussion, tuber, Traub's area, semilunar space, sixth row. Okay, so this is, it's not for you guys, okay? No, medial to lateral is sixth rib. Traub's area, okay? Sixth rib. What is Traub's area? Traub's space, usually it is tympanic, right? It is tympanic, if you see this. It has the border, sixth rib superiorly to mid-axillary line laterally. So sixth rib is, what is the Traub's area? Sixth ribs superiorly and to the mid-axillary line, left mid-axillary line, laterally border and subcostal margin. So it is like a triangle. So this is Traub's area, okay? That's very area, space. It is usually tympanic because there is bubbles, there is nothing there. Okay, there could be the gas, bubbles. But if it is not, it is dullness, that means it could be because of spleen enlargement. So spleen enlargement could be there. Or there could be any gastric, because the gastric fundus, there is the tympanic because of the gastric fundus. Because there is gas only there's nothing. But if there's a tumor of the gastric fundus, it could be, or there is a lot of food there, it will be dull. Or there is pleural effusion also, it will be dull. So remember this, okay? Nixon, you should read the Nixon method, okay? Lower border of pulmonary at left posterior axillary percussion 9 mm. Normal 6 to 8. If it is more than 8, normal size 6 to 8. If it is more than 8, yes, shifting dullness. I already told you shifting dullness.
Yes.
Abdominal auscultation is what is abdominal auscultation? No, auscultation is simple, nothing. Just hear the bowel sounds. I told you the bowel sounds usually are after every 5 to 10 seconds you will hear one bowel sound. Okay, that means in 1 minute how many bowel sound? From 12 to 6, from 6 to 12 bowel sound. Okay, so you hear, right, bowel sound because of the peristaltic activities, right? It moves, waves, right, and the food goes, the digest absorb food goes, right. So there's the sounds, bowel sounds, contractions, right, the peristaltic movement. So but if this bowel sounds, if there is decreased bowel sounds, where you can find the decreased bowel sounds? In case if patient has got paralytic ileus, okay, paralytic, the ileum is paralyzed. Ileus is after surgery, usually it happens after surgery, or in case of hypokalemia, electrolyte imbalance. It's very important thing I am telling you, paralytic ileus. That means ileum is paralyzed. What is ileum? Paralytic ileus. Ileum, the small intestine. So in case of, it happens usually, yes, paralysis. So the ileum is usually paralyzed, so you get the bowel sounds are usually diminished. But the bowel sounds are increased in case of intestinal obstruction. There's a tickling sound, increased in frequency, increase in the frequency, right? and in the pitch also, high pitched pitch. In case of don't tell me intestinal obstruction. Intestinal obstruction causes increased bowel sounds. While what causes the absent bowel sounds now? See, there is decreased, there is increased, there is normal, and there is absent. You have to remember this, right? Absent is in case of peritonitis, generalized peritonitis, absent bowel sounds, no bowel sounds. Okay? So remember these four things, right? So this is auscultation, the bowel sounds auscultation. Then you can auscultate the various, if there is aneurysm, there is hepatoma, there is any blood vessel, tumor is there, hepatoma, hepatocell carcinoma, hepatocellular carcinoma. So what happens is bruit, right? Bruit of the aortic aneurysm. You see above the aorta, above the umbilicus there is aorta, and you see the auscultation. If there is bruit, B-R-U-I-T, or there is the sound, harsh sound, it is aortic aneurysm. If above the umbilicus, around the umbilicus is aortic aneurysm. Above the umbilicus, what happened? 2 centimeters above umbilicus, it's superior mesenteric vessel. If there is bruit here, that means there is stenosis of superior mesenteric artery. Superior mesenteric artery stenosis. Okay, there is a superior mesenteric artery stenosis. There is the bruit above the umbilicus. But if it is above 2 centimeters, but laterally towards the flanks, if there is bruit, means the murmur, soft, systolic murmur, harsh murmur. So it could be because of renal arteries. 3 blood vessels you have to remember for auscultation. You are not getting me. I think you are all sleeping. One is the aorta, aneurysm, superior mesenteric artery stenosis, and third is renal artery stenosis. So these 3 is important for bruit and aneurysm. Yeah, 1 and 2 stenosis. And I told you about the auscultation is with the aneurysm, the bruit, right? So then about the sound, bowel sounds. Then about the bruit, right? Then about the friction rub, splenic rub, and the liver, hepatic rub, right? So rub in the liver and rub on the. So perihepatitis. Perihepatitis is the rub in case of this, or there is infarction, and splenic infarction also, or perisplenitis. So rub on this. So you can hear the rub, you can hear the bruit, the bowel sound with the stethoscope. This is all about the auscultation. Auscultation is very small thing, but inspection is long, and palpation. Inspection and palpation, and percussion is very important in case of ascites. Patients got the ascites. So these 3 are easy. You will remember easily the auscultation, right? So these were the things you should observe auscultation. Bowel sounds, 4 quadrant. Now I told you above, right? Hyperactive peritonitis obstruction, bruit. I told you already this. Venous hum. Heard over collateral veins disappear by heart process like bruit. You know, these are usually in the aortic, in the portal vein, hypertension, portal hyper, or inferior venous cave obstruction. So hum is the venous, make the sound. The heard over the collateral veins.
Yes.
Collateral veins, yes, it's collateral. Yeah. When you see the portal hypertension and this, so they bypass this. They bypass inferior venous cave obstruction. So, or superior venous cave obstruction. So they bypass the normal vein, and these collateral, they got the hum. Okay, the sounds. Not localized to systole, only like bruit. May disappear with changing position like bruit. So the hum can change position. Okay, so that's very important. Yes. Friction rub is seen in infarction. You see here, subcapsular, there's a capsule for spleen also, subcapsular hemorrhage. So in infarction, subcapsular inflammation of the so splenitis or perihepatitis. So splenitis, perihepatitis, then infarction and subcapsular hemorrhage. Yeah, all. Digital rectal examination, So mass, organocolation, estimated size, shapes, I already told you this.
Yes.
Okay, the difference between the left kidney and spleen. Irrespective, spleen has less marked movement than spleen with Kidney has, it is not, movement is not good like the spleen, because of the lungs. Yeah. So it has nothing to move more, and it is retroperitoneal, right?
Yes, outside of
Which other organ is retroperitoneal? Tell me next time, okay? It is pancreas, but not whole pancreas. Pancreas, then what else? Then direction of growth, kidney growth down and vertically. I told you inferiorly, down and palpation, bimanually palpable for kidney, presence or absence of notch. There is no notch. Kidney has no notch. You see, getting above the mass, kidney not for spleen. There is the mass above the kidney, but not for spleen. Percussion kidney may have overlying colonic. I told you that is the mass, the colonic resonance, colon above the kidney. But in spleen there is nothing like above the spleen, right? So this is how you differentiate spleen from the left kidney. Signs of acute abdominal cystic lesion mass or the bowel pathology. You don't have to go through this intraperitoneal excess fluid. When exceeds, it is more than half a liter, right? So these are various things absent, sensitive for ruling out increase in abdominal growth, flank fullness, flank dullness, shifting dullness, and this. Okay? So remember this. This is end. So before we go now, you should prepare now. Huh? Those things, skin, whatever like shape, movement, umbilicus, veins, everything. So you should know that, right? That's very important. Then in inspection, you see the pulsation, peristalsis. Oh, also I forgot to tell you about the splash. Percussion splash. You know that? What is percussion splash? Splash means there is the fluid, there is pyloric stenosis. You ask the patient to eat food after 4 hours, not 2 hours, 4 hours. You lift him on the pelvis, okay? Not the lady, but the man here. But the man, because I know now you are very bad guys. And you shake him, and you will hear the noise of the fluid as if the fluid is in the bottle, but it is in the half bottle, not the full bottle. If you do the half bottle, what will happen? The fluid in the half bottle will shake, right? You will hear the noise, right? Shaking noise. Shake. You know what is shake?
How I shake? Man.
If you say this in US, say shake, it will kill you. Okay, shake them, and you will find the fluid. Tell me why? Why there is shake? Why there is fluid there? Because of the pyloric stenosis again. There is no outlet obstruction. The food, everything, that water, drink, you drink water, it doesn't go because there is stenosis. So all the water is accumulated in the stomach. And you do, anybody, man, anyone. So you shake him, and you will hear the noise. So this is known as succession, not percussion. Succession, succession, SSION, succession. This is your problem to get this. Succession, yes, succession. SUCCSSION, splash. It's like a splash. Splash means anything in the bottle, you splash. There's a splash, right? It moves. The water moves all over here, right? And you hear the noise. This is succession. This is very important also in pyloric stenosis. In pyloric stenosis, this is very, very important. Remember this, right? Okay. This is important, my dear, right? So it is like the how. So these are the pyloric. So anything else you forgot? Then after palpation with all the organs. Then we do the percussion for fluid thrill and auscultation for, I told you about the auscultation about the bowel sounds and for the blood vessels, right? 3 blood vessels are important: the abdominal aorta, superior mesenteric artery, and renal arteries. Yeah. So and the bowel movement. Usually the bowel sounds are present normally 5 to 12 every second, right? After every 5 to 10, 1 second. Every 5 to 12 seconds, one sound. So 6 to 12, okay, per minute. So decreased in case of paralytic ileus, right? Increase in case of obstruction. intestinal obstruction and absent in case of peritonitis.
Yes.
This is enough for you. And about the suction slab, anything else I found no. And the difference between the kidney, left kidney and the spleen. Yeah, this is very, very important.
Yes.
So umbilicus you have to remember and shape and this, everything, right? Abdominal wall. Don't tell me if I ask you what is the normal respiration in you and me. You should say abdominal thoracic, not thoracic abdominal, right? This is, yeah, in women and in kids. Because they are in kids, especially because their abdominal wall is not this. Yes, yeah. In case of this, there is not this, right? So this is very important. The muscles are not so developed. So that's, and in case of female, because of pregnancy, other things, they are
This part.
exactly. So anything, any question?
No, thank you.